Well, welcome back. I'm now joined by our panel of experts to discuss what we heard from our patients. It's a delight to introduce our distinguished panel. From the Netherlands, Professor Wytske Fokkens. She's an ENT specialist based at the Amsterdam Medical Center. She's also CRS chair of EUFOREA. From Sweden, Professor Pernilla Sahlstrand-Johnson. She is an ENT specialist at Skåne University. From Belgium, Dr. Manon Blauwblomme. She is an ENT resident in training at Ghent University Hospital. Now, she will provide a crucial early career perspective. Also from Belgium, Professor Guy Brusselle. He is a world-leading pulmonologist at Ghent University Hospital. He's also a GINA Executive Board member. And finally, representing the advocacy perspective, also from Belgium, Dr. Xander Bertels. He's a representative of the EUFOREA Patient Advisory Board. He's also advocacy manager at EUFOREA. Let's start, if we may, by getting your initial reactions to these three specific ambitions of care, which were highlighted by our patient panel earlier on today. Professor Fokkens, let's start with you, if I may, as always. Now, from your perspective, as an ENT specialist, what are your immediate thoughts, particularly on that ambition to reach half of newly diagnosed patients and every patient under specialist care with trustworthy education and also with trustworthy empowerment tools?
Well, thank you, David. That's an ambition.
Quite.
That's definitely an ambition. And you could say on the good side, we have significantly improved. And EUFOREA has played a wonderful role. EPOS has played a great role in educating patients. But the problem is we always only get to a more illiterate part of the population that actually read things, who are interested and are not afraid to ask questions. The problem is that there's always a big majority that still says, yes, doc, tell me what to do, doc, which is, of course, not what we want. And to reach all those, I think the only thing we can do is really try to have a number of different ways to interact with patients, not only written material, but videos, podcasts, whatever, to try to reach as many as we can, but it is not easy.
No, Guy, perhaps you'd like to comment on this. I mean, also, it's very dependent on the patient, on the physician as well. I mean, as a patient, sometimes physicians aren't very forthcoming, shall we say, in terms of engaging with their patients.
It was a very important message from the patients, hearing their journey. Sometimes it took a long time for a proper diagnosis was made, and then even an optimal management and treatment was installed. So I think the centers of excellence is very important in linking also clinical care with clinical research and medical education. But to my opinion, what we need in each hospital, in each polyclinic, not only in Belgium, but worldwide, is that ENT specialists and respiratory physicians work together, even in an informal way. But that would help the proper diagnosis and earlier access to treatment for patients with either Nasal Polyp Syndrome or asthma, or often the combination of both.
I mean, it was interesting, you and I were speaking actually just before we came on air about the fact that you hold clinics with another clinician next door. You may not necessarily talk to each other, but you can open the door and say, what do you think about this? Absolutely.
So at Ghent University Hospital, already for 20 years, I, as a respiratory physician, work together with Philippe Gevaert, Klaus Bachert, Manon, on a weekly basis, where we see the same patients separately in separate rooms, but then we exchange our views and we decide together for the optimal treatment, which is not only for biologicals, but also whether we should start with specific immunotherapy and other management strategies. It's extremely important because many patients with asthma, severe asthma, they have also nasal polyp syndrome, up to 40%, but they are not aware of this. And vice versa. Many patients with nasal polyp syndrome, up to 60%, have also concomitant asthma, but the diagnosis has not been made. So it's critical that ENT specialists and respiratory physicians work together closely and improve the accurate diagnosis and early optimal management.
Just coming back to your point, Wytske, if I may, just about education. This is also very dependent, not just on the physician, but the patient as well. Because sometimes I think patients are frightened of physicians. They're frightened of being told something they don't want to hear. And also, I think when you're sitting in a consultation, often you hear things or you listen to things, but you don't actually hear what the physician is saying.
Yeah, for that reason, I think it's so important that we empower patients, both in asking, can I record this? You know, I always offer that to my patients.
That's right.
Please record what I say, because your partner will ask tonight, what did the doctor say? And then if I go to the doctor, I forget half of what they tell me, so I assume it's the same for other patients. So that's really helpful. And also, you know, Xander is now working very hard on making lists of what can you ask? Make a list before you go these are the things I really want to know. And in that way, force doctors also to share the information you need to know.
And that's a really important point, actually, Dr. Bertels. Empowering the patient and making sure the patient actually goes with a list, I think, is crucial in this.
Yeah, absolutely. From an advocacy perspective, we hear this all the time, that patients indeed go to a consultation, have, good recommendations, but they don't capture it. So I like the idea of indeed recording it, of course with permission of both parties, and indeed to get prepared before you go to the consultation. That's when you get most out of it, and that's where, on an individual basis, as a patient alone, you can already make a difference. Because, of course, this is a whole network. You have the clinicians, you have the health policy, you have the patient, but it always starts with the patient themselves. So empowering them is indeed the way to go.
And I suppose it also depends for those clinicians. They have to also know where to point the patient to go for proper education that's an accurate piece of information, not something that, as we spoke about earlier, Dr. Google.
Yeah, absolutely. And that was let's say, the highest unmet need of patients. It was the lack of trustworthy, credible information. And that's exactly why we work together with top experts to provide really trustworthy and the latest innovations in our education for patients in an accessible way, so that patients can empower themselves. It just needs to get to the patient.
Yes. Professor Sahlstrand-Johnson, if I can come to you now. We also heard from our patient panel earlier about ensuring timely access and, if indicated, timely access to critical therapies if indicated. That was what we heard repeatedly. And what I heard, and I don't know if you heard the same thing from the patients, was that simply isn't happening in many cases.
No, it isn't. As in Sweden, biologics aren't reimbursed for nasal polyposis.
At all?
No, but for asthma and urticaria. But we actually, we just written a letter to the Swedish Agency for Reimbursement in the Rhinological Research Alliance, and just emphasizing that there are evidence for biologics, etc. And there the patient associations and EUFOREA play a really important part to have an impact there. Because today we have an unequal care in Sweden, because in some regions we're allowed to give biologics, and in some regions we're not. So in the southern part of Sweden, we have 64 patients started on biologics due to nasal polyposis. But if you go a little bit further north, they're not allowed to.
So what's the rationale behind that? Why are some patients allowed them, some patients aren't? Obviously, it depends on the governance of those various areas. Yes. But surely, how are they making that decision then? Are they looking at clinical evidence, or are they just plucking things out of the air?
Yeah, well, they do, and I know they're working at the moment, and there's supposed to be patient advocacy also in the Swedish reimbursement agency looking at that. But the education is really important, both for the public and officials sitting on those important chairs. But if you have politicians in the region that think this is important, you can also affect. So we can get around it, of course, but we'd like to have a national guidance.
Yeah, and we spoke also about the role of the patient advocate, because I think it's all very well the clinician saying, look at the data, this is why these drugs are important. But when it comes from the patient to say, it's changed my life, that's very powerful.
It is, and we've seen in history that it works. We've seen with asthma and biologics, and we've seen with CF patients in the UK as well, that if patients really organize, they have an impact. So I would like to really emphasize that also in Sweden. Unfortunately, we don't have any patient association for rhinosinusitis in Sweden
Guy,
yet.
That isn't the case in Belgium, I think. I believe that you are further forward in having patient advocates talking to those bodies that reimburse for the cost of medication.
Absolutely, and this is needed. But I would to add that raising awareness to the lay public and to the patients is very important, but also to the primary care. Yes. Both GPs, general practitioners, and pharmacists, they should be aware of the new developments and breakthroughs in the domain of nasal polyp syndrome, of severe asthma, because there are a lot of patients who stay at the primary care level and are still treated with oral corticosteroids, repetitive bursts, or even maintenance treatment with oral corticosteroids. Yeah. And we all know the chronic side effects of this treatment. So it's important that we also, with EUFOREA and other means, instruct and educate the primary care physicians of the novel treatment options for patients with nasal polyps.
And so what is going wrong in primary care? Is it that some primary care physicians are interested, they want to know about the latest advances, others are thinking, well, I don't really, I'm not terribly interested in that. Is it the outreach that's going wrong? Is it the lack of continuous professional education?
It's a combination of that all.
Right.
Yes,
Okay, fair enough.
Absolutely. Absolutely. Yeah.
So also, perhaps Wytske, you'd like to add into that, just in terms of, and you and I have spoken a great deal about this actually, involving the primary care physician, because whether we like it or not, that is always going to be the first port of call. Yeah. And so in many ways, they're the person that directs the traffic. So once you come to them, they decide that clinical pathway.
Yeah, that's absolutely true. And education is very important, but also getting to the whole GP population, because there's always a group of GPs very interested in respiratory care, so they are very well educated, they know exactly where to go, who to find, and others who are very interested in neurology and just don't even recognize that patients have chronic rhinosinusitis. I think asthma is a little bit better. GPs usually at least recognize that there is disease, but upper airway disease, whether it's allergic rhinitis or rhinosinusitis or polyps, they don't recognize that at all.
And what happens in Sweden with regards to this? How do the primary care physicians match up, do you think? Do they get continuous professional education?
Yeah, and I agree with Wytske that some are really have the time and have the interest, and that really matters. And also that patients know about this, because I think if you get a patient and they read about it, have a trustworthy site to go to, they can have demands. And I wrote down a quote before from the panelist over the patients, from the dark side to going to getting your life back. I mean, of course you should get your life back, and there is possibilities, but I think you put a lot of responsibility on the patients today to really find the right info. And that is why this kind of day, the Global Awareness Day, is very important.
You see, I've done a lot of work with EUFOREA, and this is what I hear the whole time. Patients bashing their head against the desk, saying, I'm repeating what I'm doing. It doesn't work. I go back to the physician. They don't change anything. And they then have to fight for that information. And suddenly, when you get that breakthrough, they're like, hallelujah, my life has finally changed. Now, that really shouldn't be the case. It shouldn't really be up to the patient to push and shove, should it?
No. of course, but information and education is really important. I think we tend to forget that we all know what is the best, but we have to spread the word. And if you've got trustworthy sites to go to registers, to quality registers, then you get more impact.
So, Professor Brusselle, just in terms of what else we heard, you know, in terms of education, making sure that everyone is educated, but also we touched on, and you touched on it slightly earlier, about centres of excellence. They pretty much across the board, I think, said we need centres of excellence, bringing all the specialists together, whether it's in various geographical regions in those countries. We talked about it in the case of the United States, having a centre of excellence in every state. Is that practical?
I think that this is a good step forward to have centers of excellence, but to my opinion, it will not be enough because the vast majority of patients will be seen in primary care or secondary care and not in centers of excellence. So I think we need to do both, to have centers of excellence to move the field forward with also clinical research and medical education, but also to have in each hospital this collaboration between ENT specialists and respiratory physicians. And regarding education, I think we need to change habits. And now I talk as a member of GINA, the Global Initiative for Asthma. Each year we have an update of the guidelines for the management of asthma. And this is disseminated, but it's not implemented in clinical practice because this needs to change habits. And with respect to asthma, the acute treatment of an acute asthma attack is systemic corticosteroids and short-acting beta-2 agonist. But these two treatments are very bad in the long term. But still, many physicians receive these treatments by their primary care physicians because they don't know the new guidelines of GINA, and they don't change their habits. So I think it's very difficult to change habits.
It really is difficult to get people to change their habits. Can I just come back to the idea in Sweden? You spoke about it being sort of disjointed in terms of the reimbursement of cost. What about centres of excellence? Would that also be quite disjointed based on where you live?
Yes, but I really believe in the idea of it. I have I worked with Centre of Excellences, and it's really, you have to have a long-term view. It takes around 10 to 20 years before you really have it. But it gives such a knowledge and a comfort to the physicians and the patients that you get all the sides of all the specialists. So I believe that, yes, we could have it, and it takes a good clinical setup with outpatient and inward patient techniques and possibility to diagnose allergy test and olfactory testing. You've got the multidisciplinary teams. You've got the research, of course, which make you proud, and then you can spread the knowledge. And the education, of course, and both for residents, specialists, primary care, and the public.
Pernilla just said it's going to take 20 years to get all of this in place. Where are you in the Netherlands in terms of establishing centres of excellence?
Well, I think in Amsterdam we have already a centre of excellence for 20 years or so. And the good news is that after 20 years of training residents, they spread over the country, and now I know in every part of the country where to send people, to send them back, because you don't want to have them forever. So say, okay, you can very well go to Dr. X because I know he's capable and knows the right thing. So I fully agree. It takes 20 years.
So you've incubated them and sent them around.
I think we're quite good at the moment.
Sorry.
And I don't think it's going to take 20 years in Sweden, but it takes around 20 years to going there. So hopefully in few years, but so you really have to have resilience in working.
And Guy, your experience of this, would it be the same that it actually takes that sort of duration of time to set up a centre of excellence? Are there bottlenecks? Are there clinicians that say, well, I'm not really that keen?
So absolutely, it's 20 years we work together at Ghent University Hospital, ENT specialists and respiratory physicians, but you need to make decisions because it's challenging. You need dedicated time, and you need to have mutual respect and collaboration, but it's so rewarding. It's so rewarding. Actually, the first investigator-initiated studies of biologicals in nasal polyposis were performed at Ghent University Hospital. And we had to beg to the companies to give us the treatments to investigate it.
Wow.
Because at that time, in the nillies, there was no interest in nasal polyp syndrome.
Yes.
Not yet. Until then, the results were published and showing the efficacy and the safety of the biologicals in nasal polyp syndrome.
How fascinating. Dr. Blauwblomme, if I may come to you now. You are currently in training. What role do you see? You heard about the journey here, it's going to take 20 years and stuff. What role do you think you play, your fellow colleagues play? You're obviously being taught by the best and the brightest in the world. What role do you play then going forward?
So now the reimbursement in Belgium was since 2022. So we started patients in 2022 on biologicals. And then we needed like 1 hour to educate the patient, to give the injection, to get like the full explanation. And of course, 1 hour for a consultation is too long. So we did it aside from the consultation with the doctor. I did it together with the nursing team. And since then, in 2 years now, it's already a lot of changed. And we need around 30 minutes for each patient to educate the patient. And still, they call us back for information that they didn't get or something. Yeah, so we always get a lot of calls. So it's very nice to say to the patients right now that they can go to the education platforms and to the EUFOREA websites to have a lot of information. But also, since 2022 until now, a lot has changed also in the biologicals. So patients come back to us 1 time a year, probably, and they miss a lot of information in that year. So it's very nice to now have these platforms, but also for the ENT residents in training. So I think there's a lot of uncertainty around the ENT residents because they don't get the big picture. They have the information, the theoretical information, but not the patient side. So the question.
Just clarify that. What do you mean they don't have the big picture?
The practical questions.
Right.
So how does it work? What will it be in the future? What can you say? Like the implementation of this in my life and how is the outcome for me? And I think that's for an ENT resident, it's still they're not so confident to answer these questions. So all my ENT colleagues, they go to the EUFOREA platforms to see the patient side and to can answer the questions from the patients. So I think that's a really, it's.
Well, I mean, that's fantastic to hear, isn't it, Wytske?
Mm-hmm.
Just in terms of that, just listening to the discussion that we've had so far, what are your thoughts on the role of patient education? I think the world has changed dramatically. Certainly when I trained, the patient was to be seen and not heard. And now it's all about empowering the patient, making sure we heard. The patient comes in with a list of questions, which Xander talked about, that the patient should be in control. They need to get the information back from the physician. Are your contemporaries open to that, to work with the patient as opposed to sort of being rather more dictatorial towards the patient?
Of course, they're very interested in educating the patient and get a lot of information to the patient. But I think the biggest problem is time. So we have like 15 minutes, 20 minutes for each consultation. And when you want to answer every question, there's not a lot of time. So we have the consultation with the ENT resident, which is fine. And if the patient still has questions, they can come to us or to the nursing team.
And have you seen a change in the patients themselves? Are you now seeing
yes.
more well-versed patients who know more?
Yeah, of course. In the beginning, it was like, I'm coming here for an injection. I don't know why. And right now it's like, oh, how is it working? And like the grades in the polyps, and they know how we grade them and how like the SNOT 22 questionnaires, they get a lot of information. And I think that's a lot better since 2-3 years.
Excellent. Good to hear. Very good to hear. Well, let's now turn our attention to healthcare policy. I think we need to talk to you, Dr. Bertels, about this. So from a policy perspective, given that you represent, obviously, EUFOREA, your initial thoughts really on these ambitions that we've spoken about, these 3 big ambitions?
Yeah, I would like to start with focusing on faster or rapid access to innovative treatments when clinically indicated. And that's where policy can make a real difference. And what I think is that we should be really using existing data from excellent registries, including in asthma, where we have outcomes for nasal symptoms, and use that as extra evidence, real-world evidence, to speed up and fast-track also these procedures, because they take too long for patients. They are also diverse. Across Europe, there's a huge diversity in how these talks are being done, because it's on a member state level. This is totally different, of course, in the US. And I think their health policies should be more ambitious.
And from your perspective also, EUFOREA in many ways, I suppose, acts as that sort of overarching bridge between all the different countries in Europe with their different policies and their reimbursement schemes and so on.
Yeah, absolutely. With the Patient Advisory Board, we work with patients representing several European countries. And that's where we have both cross-country differences and within-country differences. And this gives us a wealth of information, patients raising their voice, advocating for their needs. And I think it's our obligation to do something with that. And to have this implementation step, indeed. You have a lot of scientific results that are really great. We need to implement that into daily practice. And I think that is really key. And there are some occasions where we can sort of advocate for this. For example, this year there will be a United Nations policy meeting on the prevention and control of NCDs. So NCDs are non-communicable diseases. So asthma, CRS, they fall under this term. But the chronic respiratory diseases, where asthma and CRS fall under, they are mostly neglected. And I think this year is really crucial to step up our game on that matter, because currently, there's been a lot of improvements in cardiovascular care, oncology care, diabetes care, but CRDs have been neglected for too long.
And just in terms from a policy perspective, where do you come in terms of pushing multidisciplinary care, also pushing to various organizations the need, as we've heard repeatedly, for better patient education as well?
Yeah. There, I think it's on several levels. So policy change can go from a very international level to a national level to really a hospital level, because you have managers in hospitals that also shape the guidelines of how many time a physician has for his patient. And I think there a lot can and should be changed, and to promote multidisciplinary care, to allow that really, because otherwise physicians are pushed into, a certain role. And I think that needs to really be critically addressed. And from the educational perspective, I can only advocate for public health institutes to talk to medical societies, to talk to patient organizations, and to see all the excellent material and output that is already there, including the patient portal, and help stimulate that to get to the patient.
And just very quickly, what are your biggest challenges in trying to push these three pillars?
Oh, too many. Too many challenges. Okay. Including with reaching to primary care is very challenging, because they address all conditions. And there, I think, getting the mindset right that all of these diseases, including Nasal Polyp Syndrome and asthma, COPD, chronic rhinitis, that we can get really succinct and brief information to a GP with the key actions and the latest actions, really. And I think that would make a difference already.
I think it's fascinating, actually. The first discussion came from the patients, and actually I think that's the right way around, that then the clinicians are put on the spot as a result of what the patients are saying. Just in summary, Wytske, from everything you've heard today from the patients, from what you've heard from your colleagues, what for you and people watching at home, what would be the biggest take-home message or indeed your aspiration going forward?
I think most important is for patients, don't accept less than what you can get, and know what you can get, and go to your physician to get it. And for physicians, I hate the text, we don't have time. Then we make time. you know, and they're all definitely in ENT. There are also patients who come in and are out in 2 minutes because it's very simple. And then we have a lot of time to have combined clinics with our pulmonologists, so important. And of course, we can also try to get our managers and say, why does the pulmonologist get half an hour and me only 10 minutes for the same patient? That's, of course, a fight we have. But the start of that fight is showing as a physician that we can do it. And that we can just say, we need that time, and we take that time, and then see what happens. And I really hope that that will improve the care for such an important group of chronic patients.
And Pernilla, what would you say from the discussion today, both discussions actually? What's been your take-home message, or indeed what you want to achieve going forward?
Yeah, I think we need to speak a language that everybody understands. The patients and the officials taking the decisions to what kind of treatment we can give. And I think we learned from the COVID pandemic that we need easy access and easy to understand information for all the patients. Because otherwise people find it on Dr. Google, as you said. And so we need to adjust to that. And I think EUFOREA is on the right track with that.
Good. Very good to hear indeed. Manon?
I would say that we need to take initiatives to get like hands-on training for the ENT residents in training, and to get like practical training, and to take the initiative themselves to educate themselves and to give the right answers to the patients, and to take the time, of course, in the consultation to answer all the questions. I think that's very important in the future for the patients and for the ENT residents. Yeah, so they can take it to the future hospital they get. Yeah.
Well said. Guy, just based on your experience in the field and what you've seen and the journey it's been on, your thoughts?
I think 2 points. First of all, we should be ambitious, both patients and physicians. Giving severe asthma as an example, nowadays, with the advent of the biologicals, we can obtain clinical remission. And clinical remission means no symptoms, no asthma attacks, no use of oral corticosteroids. That's very important. And secondly, time is money, because the longer the duration of severe asthma, the less likelihood to be able to obtain remission in these patients. We have vast amount of evidence from many registries, national registries all over the world. The longer the duration of severe asthma before the start of an add-on therapy with a biologic, the less likelihood to be able to obtain clinical remission. So that's I think, a key message to patients and physicians.
So reinforcing the point, you want timely access to those therapies.
Absolutely. Accurate diagnosis and timely start of the treatment.
And finally, Xander, your thoughts on the wide-ranging discussion we've had.
Yeah, I can only agree with all the take-home messages of the colleagues here. My message would be that the time is now, and that it's really been decades where we have been improving a lot of things, mostly from the clinical side, from the patient side, but now we need to improve also policy. We need to implement it and get these kind of things to address them and make sure that patients have remission, clinical remission in daily practice, and I think that's a beautiful mission, to give hope to patients.
Fantastic. Thank you very much indeed. Well, thank you very much indeed to all my panelists for taking part. Thank you to all of you for watching. I really do hope you found it enjoyable, useful, and enlightening. Until next time, from all of us here in Brussels, goodbye.